Hello, everyone. We're gonna redo my stroke lecture from a few weeks ago because I had all kinds of technical challenges that day. For Cameron, our student, this is a talk that was requested by our staff about stroke anatomy and classic stroke syndromes. So just going sort of globally down, I wanted to talk first about the overall structure of the brain. It consists of the cerebrum, which is basically the top part, which contains the cerebral cortex, the basal ganglia, and the limbic system. Below, going from sort of front to back, is the diencephalon here, which consists of the thalamus and the hypothalamus and the pituitary gland. And the back here we have, or caudally is the appropriate way to say it, is the cerebellum, and then the brainstem, which is further broken down into the pons, the medulla, the midbrain, the pons, and the medulla. The cerebrum is further divided into various lobes. These are the frontal lobe, which is predominantly housing the motor cortex, the parietal lobe, which we think of as holding sensory functions and the optic radiations for the visual system, the occipital lobe, which houses most of the visual pathways, and the temporal lobe, which has many functions, but most notably hearing and smell, and then memory is housed there. Further down, we talk about the deep nuclei, the basal ganglia, which is predominantly concerned with coordination of movement. This consists of the caudate, the putamen, and the globus pallidus, the various nuclei of the basal ganglia, which are really involved in coordination of movement, which is why folks that have strokes or other lesions in that area will have a Parkinsonian type syndrome and difficulty with movement. The limbic system is really interesting area that we probably don't deal with very much here, but houses the amygdala, the cingulate, and the hippocampus, so a lot to do with memory and emotions, and lesions here will give you sort of your dementia type syndromes. The diencephalon, as I mentioned before, it consists of the thalamus, which is really like a circuit board or a relay system integrating all of the various pathways of the brain from the cerebral cortex down to the brainstem. A lot of sensory function is housed in the thalamus, and that's why folks with strokes or hemorrhages in this area have a lot of pain and sensory deficit. Next is the hypothalamus, which is sort of, I think of as a glandular function, endocrine function, which is involved with thirst, hunger signals, and also your autonomic functions. This is kind of what we think of when our patients are storming, or I thought about this the other night when the guy with the ICP monitor, when he was having high fever in the setting of all of his ICP crisis. It's really the hypothalamus is getting revved up just by pressure. And then also part of the diencephalon, which is really arguably not really brain, are the pineal glands, which is what is involved in also in hunger as well as sleep-wake cycles. And then the cerebellum, I think I said on Monday, it's not really the brain, but you can already see it looks so different. It's arranged in these this leaf-like structure. So it's really involved in coordination of movement, balance, and position sense. And secret about the cerebellum is you don't need very much of it. But next down in our organization scheme is the brainstem, which consists of the midbrain up top here, the pons, which is the big belly, and then the medulla, the lower portion. Important structures to think about here. This red piece here that runs sort of craniocaudally down the entire brainstem is the reticular activating system. This is like the on-off switch for your consciousness. folks that have any kind of lesion involving the reticular activating system, whether from stroke or from compression, or other types of lesions, will have impaired consciousness. And that's why, when we have a family meeting and somebody has a brainstem stroke that involves the reticular activating system, we can say with some degree of confidence they're not going to regain consciousness, because that's what this entire structure is involved with doing. Very, very important part. The other territory in the brainstem that's very salient is it houses all of the cranial nerve nuclei. I included this diagram here just to sort of show that the way they're organized, sort of top to bottom, and the cranial nerve nuclei are housed within the brainstem, and then the nerves themselves exit out through whether cranially or caudally, depending on which level you're talking about. And these all serve essential functions within the face, but also the control of breathing, circulation, and alertness. So this is where we sort of transition into the stroke part of the talk, the vascular anatomy. This diagram I included over here is just to sort of show the circle of Willis, which connects all of the parts of the cranial circulation. We've got the paired anterior communicating anterior cerebral arteries in the front. The anterior communicating artery is this little bridge here. These travel around, your ACO travel around and meet up with, this is really oriented strangely in this diagram. These are kind of in a third plane going up, but your paired internal carotid arteries, which branch here to form your middle cerebral arteries bilaterally, and then your PEEP-COMs, or posterior communicating arteries, going back. And this was very well designed, basically, so that you have a circuit. So a lesion anywhere in this pathway, you can still get, it's a protective mechanism, so you can still get circulation throughout the circuit elsewhere. And we really see failure of circulation when either there's not, where it's completely obstructing somewhere, or it's for sort of further out in the pathway. But this circle here, kind of have to imagine, like, if I lesion here, what's going to happen? But just know that it's all connected. We have a basilar artery patient at the moment that's pretty rare stroke. But that here is consists of the posterior circulation with the basilar and the paired vertebral arteries that go down. And then the anterior spinal artery sort of branches off here and feeds the spinal cord. Other important parts of the posterior circulation are the ICA is the anterior inferior cerebellar artery, and the pica, which is where, on this diagram down here, the posterior inferior cerebellar artery, and these we'll talk about later because they have very notable stroke syndromes. These diagrams here, I think the last time I gave this talk, I was trying to explain how this is what what a neurologist sees when they think about this anatomy, is that you think about where the territories that's supplied by any given cerebral artery. So you've got the paired ACAs that are really medial up here. The MCA territory is this wedge-like piece here, everywhere in yellow, that serves sort of the frontal, temporal, and parietal lobes. The posterior posterior cerebral artery is this piece in the back, which gets both occipital lobes. And then these I would worry about less because these are sort of smaller distributions. But we kind of just learn to memorize these so that you correlate this area with scans when you're evaluating where a stroke has taken place. Probably too basic for this talk, but there's two stroke types. This talk is mostly focused on the ischemic type strokes, but also we have hemorrhagic strokes. Ischemic strokes are several mechanisms, but the predominant ones are the thrombotic or clot type strokes and embolic strokes, which means the stroke travels from another source. These are further, the thrombotic strokes are further broken down into large vessel, meaning they involve a large vessel like the MCA or the ACA or the Basler, and then the small vessel strokes, which involve these smaller branches. For example, these here, these are the lenticulostriate arteries that are branches off the MCAs. And if you recall, these deep structures here are the basal ganglia. So there are many classic stroke syndromes that happen here that are a result of small vessel strokes. The reason that we care about this distinction is that generally speaking, the location of the stroke may have a different pathophysiology. So we know that different types of strokes involve the small small vessels versus the large vessels. Oh, and then I included this here just to review the different sources of embolic stroke. So, there can be cardiac masses like an atrial myxoma, a ventricular thrombus that forms, for example, in the setting of AFib or any kind of clotting problem. Or they're the folks that have a patent foramen ovale and have a paradoxical embolus from below, from like a DVT. So now to the stroke syndromes. The first one I included are the ACA type strokes. And remember, I showed you that colorful diagram that showed this sort of very medial aspect here of the frontal lobes. This is your classic ACA distribution stroke. It really involves the very either side of the fox, this yellow territory here. And this, if you remember from anatomy, the homunculus, which shows where different motor pathways are mapped onto the cortical surface. Your legs are really what are in the middle there. So any lesion of the anterior cerebral artery will give you a very medial stroke like this, and will give you predominantly leg more than arm weakness. The other features that are typical of an ACA stroke are apathy or abulia. So these are the patients that just are like a bump on a log, don't really want to participate in care. They may be disinhibited, and so frontal, we say frontal, and so they're kind of grabby and inappropriate. And another feature of this, and I don't really understand why, but incontinence is a frontal lobe pathology as well. The ICA, that's the most proximal part of the intracranial circulation, so that has the most devastating kind of stroke. It'll consist of aphasia or neglect, depending on whether you're involving the dominant side or the non-dominant side. You will see a gaze deviation to the side of the occluded artery, and potentially a field cut if you can tease it out. Because the MCA, if I go back to my circle of Willis here, because the MCA comes off of the trunk of the ICA here, a lot of your stroke syndromes are going to be similar, involving aphasia on the dominant side and neglect on the non-dominant side. And then loss of motor and sensory function of the face and arm more than the leg on the contralateral side. And the reason being the leg is less involved is, remember, I just said that your ACA is really where your leg territory is mapped. So as you come out this way on the motor strip, you're getting more arm, face, etc. Arm and face. You can have a homonymous hemianopsia contralateral to the lesion if you're involving territory where the optic radiations pass. And then as you go sort of more distal out from the source and the MCAs, you can branch into the superior and inferior divisions of the ACA. So these are the clots that come back from IR, and maybe they got the proximal piece, but then they'll say there's a piece that ended up in M2 and M3, so they're out in the branch points of the MCA, and these folks will have a more specific aphasia because they're involving either the Broca's or Wernicke's territory, sort of depending on which way it goes. This I included here. This is a piece your typical PCA stroke involving the occipital lobe. These folks will have a contralateral to the side of the lesion field cut, and they'll have this interesting phenomenon of visual agnosia where you can see things, but you can't describe what you're seeing. Depending on where it is, you may or may not have, you may have alexia, an inability to read, plus minus agraphia, which is the inability to write. Prosopagnosia, which is face blindness, and this I found on the internet of what apparently faces look like to folks with visual agnosia. And then if it's bilateral, you may have total blindness if you have both occipital lobes. And also amnesia is implicated in that type of stroke. It's a rare type of stroke and usually embolic. So just remember when you hear PCA, a lot of visual phenomena. Now going further back into the posterior circulation, you got the superior cerebellar artery. These folks will have dysmetria because they're involving a large territory of the cerebellum. They also may have a Horner syndrome because of the pathway of the autonomics. And contralateral loss of pain and temperature, and a fourth nerve palsy, depending on how extensive the stroke is. Can I move this? Yes. Oops. So this is a cross section here of the medulla showing the pica infarct, posterior inferior cerebellar artery infarct, which is one of the ones I had has a very characteristic stroke syndrome known as the Wallenberg or the lateral medullary syndrome. You will be pimped on this when you go to residency, and you have to name all of the various features of it and why. But basically, it consists of this lateral portion of the medulla, which is on the MRI here, this little tiny spot right here. And these folks will have a Horner syndrome, which remember is meiosis, ptosis, and loss of pain and temperature on the face, as well as ataxia because of the spinocerebellar tract involvement, and then palatal weakness, which is why, probably because of this nucleus solitarius, the 7 and 9. So just in this tiny spot here, your real estate is so high within the medulla that you can get so many vital tracts that you get really a very large and devastating stroke, which I find kind of neat. Not neat for patients, but neat anatomically. I think I froze. Or is that the end? It's not the end.
Tech support?
Maybe. No, it's not the end. I'm first. Oh, there you go. Thank you. Here's a little, I included this just to reorient us. So your superior cerebellar artery is for this top portion. The ICA, anterior inferior cerebellar artery, goes to the middle third of the cerebellum. The pica is the one we just went over that involves cerebellum and obviously medulla. So the ICA, which is this middle portion, again, can involve some hearing loss because it's at the level of the pons where the cranial nerve 8 is. The ipsilateral facial weakness and sensory loss, again, from cranial nerve involvement. Ataxia and vertigo, which is really the cerebellar component. And then contralateral decreased pain and temperature because of the pathway of the spinothalamic tract. Basilar stroke, a really devastating stroke syndrome, which involves that reticular activating system that we talked about earlier, which is why you'll have a depressed level of consciousness. You may have eye movement and facial palsies based on pontine dysfunction. ataxia, and ultimately, and quadriparesis, and ultimately what's a complete infarct will give you the locked-in syndrome, where you really have preserved alertness, but inability to move the face or the limbs. And these folks classically will only be able to move, potentially have vertical eye movements preserved. And so they can sometimes develop like a communication system by eye movements, but catastrophic stroke. And this just shows again, by vessel, how much of the cerebellum you're going to end up infarcting. And then a reminder that there's 3 vascular territories of the cerebellum. The lacunar syndromes could be a talk on its own. These are deep, small vessel strokes that involve occlusion of these lenticulostriate, or these little small perforating arteries that are branches off of your MCA. These hit and lesion the basal ganglia nuclei, and have, again, depending on which territory is involved, they have named syndromes, which for the most part are exactly what they sound like, but you can have a pure motor syndrome, an ataxic hemiparesis, clumsy hand dysarthria, a pure sensory stroke, which is obviously one that involves the thalamic nuclei more than any others, or a mixed motor sensory stroke. As I said before, these strokes that happen in these tiny arteries are really of a different type of mechanism than the ones that involve the large vessels like the ICAs and the MCAs. I think we very rarely will get folks like this in the unit, just because these strokes are not so devastating. And also these ones are not ever going to be the type that go for thrombectomy. So these folks, a stroke of the lacunar arteries will go to the floor for the most part. And now is at the end. These are some references which I recommend. When we're looking at MRIs, that we look at this and we say the stroke is not where we expected it to be, or it's larger than we expected, because you know where you memorize, well, an MCA stroke is going to get this whole yellow territory, but a good outcome, for example, from a thrombectomy is that it only involves like a little speck over here, because they were able to revascularize so much of that MCA territory that was at risk. That's the story for this guy right here in 7. You know, he had an ICA occlusion, so he really should have had ACA, MCA. He should have had the whole hemisphere out, and he has a little piece of the ACA, and then like a little nubbin over here in the temporal lobe, but more or less all of it was preserved by the thrombectomy. And then as far as basilar strokes go, you know, really you probably would expect to see the entire brainstem out. Mr. 15 is sort of patchy, so his was a moderate success. I mean, he's not locked in, right? He doesn't have that syndrome of complete quadriparesis and inability to move the face, but he does have a very extensive stroke if you go and look on his MRI.